Today, proteasome inhibition is recognized as an important part of the treatment for multiple myeloma. But patients and doctors didn't always have this life-extending option. In fact, it took decades for the benefits of proteasome inhibition to be fully understood. Let's explore the pathway to proteasome inhibition. In the 1980s, a hypothesis regarding proteasomes emerged among scientific researchers. Since proteasomes degrade unneeded or damaged proteins, then diseases involving excessive proteolysis could be affected by proteasome inhibition. This insight sparked researchers to look for potential uses of proteasome inhibitors as novel therapeutics in protein-generating diseases such as multiple myeloma. As research into the role of the proteasome expanded, scientists observed that proteasomes were more than protein recyclers. In addition to degrading unneeded or damaged proteins, these master cell regulators also affect transcriptional activation, cell cycle proliferation, and signal transduction. Preclinical studies warranted further clinical investigation. In myeloma cells, inhibiting the proteasome's function led to apoptosis. Proteasome inhibition was also discovered to affect the bone marrow microenvironment, disrupting adherence between myeloma and bone marrow stromal cells, thus lessening disease morbidity. These discoveries about proteasome inhibition were about to change the multiple myeloma treatment landscape. In 2003, the FDA approved bortezomib, a first-generation proteasome inhibitor, signifying an important step forward in multiple myeloma treatment. And in 2004, 3 scientists were awarded the Nobel Prize in Chemistry for their discovery of the protein degradation process via the proteasome. Multiple myeloma is a heterogeneous disease. It manifests differently in each person and can mutate over time after exposure to different therapies. But regardless of the specific mutations, most myeloma cells have something in common. They are highly dependent on proteasome activity for cell survival. Since myeloma cells create so many abnormal proteins, they depend on proteasomes more than other cells. This critical function of proteasomes makes them a logical target in myeloma treatment. Proteasome inhibitors have been shown to sensitize cells to other therapies in vitro. 2012 saw a major milestone in multiple myeloma treatment. The FDA approved a second-generation proteasome inhibitor, Kyprolis carfilzomib. Kyprolis has demonstrated activity against bortezomib-resistant multiple myeloma cell lines. Kyprolis is indicated in combination with dexamethasone or with lenalidomide plus dexamethasone for the treatment of patients with relapsed or refractory multiple myeloma who have received 1 to 3 lines of therapy. Kyprolis can cause serious side effects that can be potentially life-threatening for patients with relapsed or refractory multiple myeloma. Cardiac toxicities, a new onset or worsening of pre-existing cardiac failure, restrictive cardiomyopathy, myocardial ischemia, and myocardial infarction, including fatalities, have occurred following administration of Kyprolis. Death due to cardiac arrest has occurred within a day of administration. Kyprolis is a different kind of proteasome inhibitor. Unlike bortezomib, which inhibits multiple subunits of the proteasome, Kyprolis binds to only one subunit of the proteasome. Today, proteasome inhibitors are recognized as an important component of multiple myeloma treatment due to the ubiquitous presence of the proteasome in all myeloma cells. This pathway of discovery and innovation changed the multiple myeloma treatment landscape for patients. Cardiac toxicities, a new onset or worsening of pre-existing cardiac failure, restrictive cardiomyopathy, myocardial ischemia, and myocardial infarction, including fatalities, have occurred following administration of Kyprolis. Death due to cardiac arrest has occurred within a day of administration. Withhold Kyprolis for grade 3 or 4 cardiac adverse events until recovery, and consider whether to restart Kyprolis based on a benefit-risk assessment. While adequate hydration is required prior to each dose in cycle 1, all patients should also be monitored for evidence of volume overload, especially patients at risk for cardiac failure. Patients older than 75 have an increased risk of cardiac failure. Patients with New York Heart Association Class 3 and 4 heart failure, recent myocardial infarction, conduction abnormalities, angina, or arrhythmias may be at greater risk for cardiac complications and should have a comprehensive medical assessment, including blood pressure and fluid management, prior to starting treatment with Kyprolis and remain under close follow-up. We've also observed cases of acute renal failure and renal insufficiency adverse events in patients receiving Kyprolis. Monitor renal function with regular measurement of the serum creatinine and/or estimated creatinine clearance, and reduce or withhold dose as appropriate. Tumor lysis syndrome, TLS, including fatal outcomes, have occurred in patients receiving Kyprolis, especially those with multiple myeloma and a high tumor burden. Adequate hydration is required prior to each dose in cycle 1 and in subsequent cycles as needed. Monitor for evidence of TLS during treatment and manage promptly. Withhold Kyprolis until TLS is resolved. We've seen cases of pulmonary toxicity, acute respiratory distress syndrome, acute respiratory failure, and acute diffuse infiltrative pulmonary disease, including some fatal events. Discontinue Kyprolis for drug-induced pulmonary toxicity. Pulmonary arterial hypertension, PAH, was reported in patients treated with Kyprolis. Withhold Kyprolis for PAH until resolved or returned to baseline, and consider whether to restart Kyprolis based on a benefit-risk assessment. Dyspnea was also reported in patients treated with Kyprolis. Evaluate dyspnea to exclude cardiopulmonary conditions including cardiac failure and pulmonary syndromes. Stop Kyprolis for grade 3 or 4 dyspnea until resolved or returned to baseline. Consider whether to restart Kyprolis based on a benefit-risk assessment. The risk of hypertension, including hypertensive crisis and hypertensive emergency, has been observed with Kyprolis, including some fatal events. Monitor blood pressure regularly in all patients. If hypertension cannot be adequately controlled, withhold Kyprolis and evaluate. Consider whether to restart Kyprolis based on a benefit-risk assessment. Cases of venous thromboembolic events have been observed with Kyprolis. Thromboprophylaxis is recommended for patients being treated with the combination of Kyprolis with dexamethasone or with lenalidomide plus dexamethasone, and should be based on an assessment of the patient's underlying risks. Patients using oral contraceptives or a hormonal method of contraception associated with the risk of thrombosis should consider an alternative method of effective contraception during treatment with Kyprolis in combination with dexamethasone or lenalidomide plus dexamethasone. Infusion reactions, including life-threatening reactions, have occurred in patients receiving Kyprolis. These infusion reaction symptoms include fever, chills, arthralgia, myalgia, facial flushing, facial edema, vomiting, weakness, shortness of breath, hypotension, syncope, chest tightness, or angina, and can occur immediately following or up to 24 hours after administration of Kyprolis. Pre-medicate with dexamethasone to reduce the incidence and severity of infusion reactions. Inform patients of the risk and of symptoms of an infusion reaction and to contact a physician immediately if they occur. We've seen fatal or serious cases of hemorrhage with Kyprolis use. Hemorrhagic events have included gastrointestinal, pulmonary, intracranial hemorrhage, and epistaxis. Promptly evaluate signs and symptoms of blood loss and reduce or withhold dose as appropriate. Kyprolis causes thrombocytopenia with recovery to baseline platelet count usually by the start of the next cycle. Thrombocytopenia was reported in patients receiving Kyprolis. Monitor platelet counts frequently during treatment with Kyprolis. Reduce or withhold dose as appropriate. We've observed cases of hepatic failure, including fatal cases, during treatment with Kyprolis. Kyprolis can cause increased serum transaminases. Monitor liver enzymes regularly. Reduce or withhold dose as appropriate. We've seen cases of thrombotic microangiopathy, including fatal outcome. Monitor for signs and symptoms of TTP/HUS. Discontinue Kyprolis if diagnosis is suspected. If the diagnosis of TTP/HUS is excluded, Kyprolis may be restarted. We've also seen cases of posterior reversible encephalopathy syndrome, PRES, in patients receiving Kyprolis. Discontinue Kyprolis if PRES is suspected and evaluate. In a trial comparing Kyprolis, melphalan, and prednisone, KMP, versus bortezomib, melphalan, and prednisone, VMP, a higher incidence of serious and fatal adverse events was observed in the KMP arm. Kyprolis can cause fetal harm when administered to a pregnant woman. Females of reproductive potential should be advised to avoid becoming pregnant while being treated with Kyprolis. Males of reproductive potential should be advised to avoid fathering a child while being treated with Kyprolis. If Kyprolis is used during pregnancy, or if the patient becomes pregnant while taking this drug, apprise the patient of the potential hazard to the fetus. The most common adverse reactions occurring in at least 20% of patients treated with Kyprolis in the combination therapy trials were anemia, neutropenia, diarrhea, dyspnea, fatigue, thrombocytopenia, pyrexia, insomnia, muscle spasm, cough, upper respiratory tract infection, hypokalemia. Please see full prescribing information available at kyprolis-hcp.com. The pathway to proteasome inhibition was one of discovery and innovation. Due to the ubiquitous presence of the proteasome inhibitors are now recognized as an important component in the treatment of multiple myeloma. For more information about Kyprolis carfilzomib, go to kyprolis-hcp.com. Thanks for watching.